So, hi, on this Instagram Live, I'm going to be talking about premenstrual syndrome, PMS, and premenstrual dysphoric disorder, PMDD. You might have noticed I've got a different background because I'm actually on holiday. So anyway, it's Sunday, so I thought I would continue as normal to talk about a condition or two conditions that I think are really underestimated, they're underreported, they're under-researched, and actually they're normalised for so many women. So thinking about PMS, premenstrual syndrome, and PMDD, they're very, very similar. In fact, PMDD is a more severe form of PMS. And you can spend hours, which indeed I have done, reading the literature, reading what the definitions are, reading how to make the diagnostic criteria. But in my mind, it's very easy to understand, yet very difficult to access the right information, knowledge, support, and most importantly, treatment. So in the next half an hour, I'm going to answer some of the questions. So thank you for all the questions that you've sent and try and make it very simple. Because what I find really frustrating and sad is something that I'm going to admit to you, that I couldn't have done this Instagram Live 5 or even 10 years ago because my knowledge was so poor about these conditions. I wasn't taught about it in the right way, but also I didn't have the wealth and depth of clinical experience and knowledge that I do now. And it's only often in medicine you learn a lot from pattern recognition. You learn from seeing and managing women in a certain way and following them up and seeing how they respond to different treatments or how they might worsen to some treatments as well. So what I'm going to talk about is actually a lot of it is based on knowledge and experience, not just my experience, but others I work very closely with who have a lot of clinical experience managing women with PMS and PMDD. Now, as you know, when we have our menstrual cycle, our hormone levels fluctuate and change, and that's what happens for most women. And so many of you will have seen graphs and charts showing that we've got our estradiol and progesterone levels that have a spike. They have a big up and down in the middle of our cycle, which is when we usually produce an egg, when we ovulate. And in the second half of the cycle, which is called the luteal phase, we have an increase of estradiol and progesterone until about halfway through. So the luteal phase lasts around 14 days. So around 7 days in, it goes up and reach its peak, and then it drops. And then just before your period is when your hormone levels are at its lowest. Now, when you look at most of the graphs that are shown, if you Google them, you can see progesterone is greater than estradiol, but actually the scale is wrong. Progesterone is massively higher than estradiol when it spikes in the second half in the luteal phase of the cycle, and then it drops. Now, just before the period is when these hormone levels decline very, very low. And in fact, testosterone does a little blip as well when people ovulate, and that level reduces as well during the luteal phase. Now, many people know, because I've spoken about it a lot before, that the presence of symptoms, especially in the perimenopause, is often related to these changing hormone levels. So often it's not the actual level of hormone per se, it's the change in those hormone levels. Now, with PMS and PMDD, this change in hormone levels can cause symptoms to occur. And now the symptoms of PMS, PMDD are actually the same as symptoms of perimenopause, menopause, but also postnatal depression, because they are symptoms related to hormonal changes. Now, I've already said before that people can have symptoms affecting every organ of our body, especially our brain, because these hormones are made in our brains as well as our ovaries. So it's not just our ovaries that are determining this change of hormones throughout our cycle, it's how our brains produce it as well. And this is really important when we think about treatment options, which I'll talk about in a bit. So we've got these changing hormone levels. Some women are more sensitive, if you like, to changing hormone levels than others. Now, most of us as women have had days before our periods where we felt dreadful. We felt quite low, we felt quite tearful, quite irritable, quite angry, quite flat, quite joyless, low energy. We might have had headaches, migraines, we might have had urinary symptoms, even some leakage or incontinence. We might have had muscle and joint pains, we might have had palpitations, we might have had skin breakouts, skin changes, hair changes. All of these usually occur just before our periods. And then for many of us, our periods come and then we go, oh, thank goodness. That's why I was having all those symptoms. And actually, for many years, it's just been normalised. I went to a girls' boarding school for many years, and most of us, actually, our periods ended up being in sort of tune with each other after a while. But many of us had symptoms, and we were just told, well, that's just your lot. That's part of being a woman. And it's almost a laughable thing, isn't it? Oh, she's a bit hormonal. Just don't talk to her for those few days. But actually, if you're one of those people that is suffering with those symptoms, it's not just a few days, it's actually really affecting the quality of your life. And we know that the majority of women, and some studies, I think quite accurately, have said it's about 95% of women experience symptoms related to PMS, premenstrual syndrome. Now, not everyone has every symptom. Some people can have a few symptoms. It's usually the symptoms affecting mental health are the ones that affect people the most, but it can be the physical symptoms such as the palpitations, the muscle or joint pains, the urinary symptoms that can affect people the most, and we're all different. We know some conditions such as migraine can be worse before periods. Epilepsy can be worse. People can have more seizures before, and this is due to changing hormone levels. Now, PMDD, premenstrual dysphoric syndrome, is estimated to affect around 5% of women. That doesn't sound much, does it? 5%. But actually, let's think about that. That's 1 in 20 women. That's a lot, because PMDD is a more severe form of premenstrual syndrome. It's when those symptoms really affect people's quality of life, their ability to function, and that's often their ability to function at work, but also at home, with family, with friends, with social interactions as well. 1 in 20 is a lot when we know the majority of these women are not receiving treatment that could really improve them. So those symptoms can be very, very disabling. They can cause a lot of morbidity. They can cause a lot of time off work as well. So they're costing a lot of money to the nation, because women are not able to do the best as they want to when they're literally paralysed with these symptoms often. I've spoken to a lot of women who've told me for those few days before their periods, they are unable to work, they're unable to even get out of the house. Some women have very low thoughts, very dark thoughts, and we know that there is an increase in levels of self-harm and also thoughts of suicide. And some people have died by suicide because their PMDD has been so severe. We've known this for many, many years, but a lot of people trivialise it or don't believe it or don't want to believe it as well. And that's partly when I speak to some academics about it, they say the research isn't robust enough. Now, one of the problems is the research hasn't been done. It's not that there's research showing that this condition doesn't exist. It's almost like people don't want it to exist because it's such an obvious cause and such obvious treatment. And also maybe because it's a women's condition, maybe it's related to periods, that people don't want to discuss and talk about it. But those women who are suffering really know it's a real condition. And so when people are asked to monitor their symptoms to try and help diagnosis, it can be very useful to download something like our free Balance app, monitor your symptoms according to your periods. But when you look at this diagnostic criteria that some people write about, it can be very rigid, whereas most people, when I speak to them, they know quite quickly whether they've got PMS or PMDD. There's not a blood test or a scan that will show whether you have it or not, but most people will think that they have, and they're probably right. Women aren't stupid. The information and the ability to talk about their symptoms to a person, able to be listened to and speak to someone who's knowledgeable about how changing hormones can affect people. So that's the first thing, is knowing yourself. Could any of these symptoms be related to my changing hormone levels? Is there a pattern to these symptoms? Do they usually occur in the second half of my cycle? And do they often improve when my period comes? Some people find they get worse when they ovulate. Like I say, you get this spike of hormones, they go up and down quite quickly. And just the change of hormone levels can cause those symptoms as well. So it doesn't always have to be the second half of the cycle, it could be mid-cycle as well. But if you try and build up a pattern, and if you're not sure, you can always ask other people, because it's very hard when you're with yourself 24/7 to know how you change. But you could ask a partner, a friend, a relative, do I have times where I'm more snappy, more irritable? Or do I have times when I'm more socially withdrawn, less likely to go out, less likely to answer messages or what have you? Because any symptoms that are having an impact in a woman's life need to be addressed. I've spoken to a lot of women who tell me their life falls apart, but not just those days where they're having symptoms. Some of you might have listened to the podcast I did with my oldest daughter, Jess, talking about her PMDD. And it was really on that podcast, it made me sit and reflect and think really about the impact or potential impact this condition can have. Because she was saying it's only a few days of the month where she was feeling very low, very joyless, very tearful, very flat. But actually the rest of the days of the month when she was feeling well, she was dreading those 3 days coming. So the rest of the time she wasn't living the life she wanted to because she was so worried about those days coming. And it's like anything. When you feel well, you forget what it's like to be ill or unwell. When you're happy, you forget what it's like to be sad and joyless. But when those emotions come, it's very hard to change. It's very hard for people to just snap out of them. And it can be this downward spiral that can be so damaging and detrimental, especially to people's mental health. So, I've already said PMS and PMDD and postnatal depression actually are related to changing hormone levels, often the progesterone and the estradiol that drop and change. I've said that it's quite hard sometimes to make a diagnosis clinically. If you're expecting to have a proper formula, proper blood test or a scan, it's not going to happen. The easiest way of making the diagnosis is by listening to patients and for us as patients to help make that diagnosis together. So it's related to changing hormone levels. We can make the diagnosis often if we're given the right information. So then what about treatment? And this is really important, isn't it? Because in medicine, what we like to do is treat the underlying cause. Now, if you read most of the guidelines and treatment pathways for PMS and PMDD, they'll talk about lifestyle changes. They'll talk about antidepressants. They'll talk about removing the ovaries or giving treatment to block the ovaries working to reduce hormone levels. But there's nothing really top line saying about giving hormones back because it's related to a hormonal change. And this is where I think it's really difficult actually for clinicians. And it's really hard for patients to receive the best treatment often for them. And I remember about 10 years ago sitting in a clinic in London with a menopause specialist. And one of the patients that came in was a young lady who was only 26. And she'd come for her second appointment and she had PMDD. She'd had it for many years. She'd been given treatments, including lifestyle treatments. She'd been given the contraceptive pill and it hadn't helped. It had made her feel worse. And she'd also been given some antidepressants and they hadn't helped. So she was coming back to tell the consultant I was sitting in with that she actually felt better and her life had been transformed with this very simple treatment he'd given her. And I was desperate to hear during the consultation what he had prescribed for her. And what he'd prescribed for her was some hormones. He'd given her some estrogen gel and some natural progesterone in the form of Eutrogestan. And after she'd left the consultation and she literally skipped out the room because she was so much better, I said to this consultant, I've never seen that given for people before. No one had taught me. And he said, Louise, it's the most obvious thing. All I've done is topped up her hormones in the second half of her cycle when her hormone levels are low. And this has transformed her life. And this is what we do a lot. And I've done it for many, many years, but people haven't listened. And I went away and reflected and I thought, this is so embarrassingly simple, But often in medicine we forget the simple things. We're often thinking about giving drugs to put sticky plasters over a problem. We're forgetting the underlying cause. And so since then I've learnt a lot, like I say, from patients. And so the big question is, which hormone and how do we give it? And everyone's different, of course. So as a generalisation, I've already said this drop in progesterone is quicker and more than the drop in estradiol. And often in women, we see that they are more progesterone deficient. Now, when I say progesterone, it might be worth listening to the YouTube I've done all about progesterone, because there are different types of progesterone. When I say progesterone, I mean the natural progesterone that our body produces. I don't mean synthetic progesterone. So any contraceptives, and even the progesterone-only pill, the progesterone implant, the progesterone injection are all synthetic. They've been chemically altered, so they are not the same as natural progesterone. So when we give treatment for PMS and PMDD, the important thing is really to begin with is the natural hormones, because you want to replace like for like. You don't want to give something that's synthetic if you've got a natural alternative. So often we will give the natural progesterone as a low dose often to just top up what's missing in the second half of the cycle. If a woman is feeling really well for the first 14 days or so, why give her any medication then? Often it's when her symptoms are occurring, so we will give the progesterone then. There are different ways of giving progesterone, so we can give it orally as a capsule. In the UK, it's often called Utrogestan. But when we take it orally, it gets metabolized. It goes through the liver, it gets metabolized and broken down into other types of progesterone. Some people find that's fine. The types of progesterone that it gets broken down to can be beneficial for some women. Some women find that they don't tolerate the Utrogestan very well. And so sometimes we give vaginal, so pessaries of progesterone. There's something called Cyclogest, which is a pure progesterone, so it's a natural progesterone, it's body identical, and it can be given either vaginally or rectally as a pessary. It comes as a slightly higher dose, usually either 200 or 400 milligrams, depending on the prescription, and that can be given at a higher dose, so it can sometimes we give it 2, 3, 4 times a day. It's a very short half-life. It doesn't last very long in the body, and the dose really does depend on the clinical response. And paradoxically, some women respond better to a higher dose than others. I see some women who say, no, I can't tolerate progesterone at all. It makes me feel very low. I don't enjoy it. I can feel sometimes a bit nauseated, maybe a bit bloated. But then when you give it vaginally at a slightly higher dose, it actually stimulates the receptors differently and people do feel better. So it's really important, if you think you can't tolerate progesterone, make sure you've gone through the proper options with your doctor or clinician, because some people, they don't respond well to the synthetic progestogens, which are biochemically and structurally very different to the natural progesterones. I've seen a lot of people who haven't tolerated Utrogestan, but they have tolerated the right dose for them as a pessary. And all we're doing is topping up those hormones. It's not used as a contraception, it's used for the treatment of PMS and PMDD. So we know for many years there's lots of clinicians across the world that have used progesterone with very good responses, but somehow progesterone has always had a bad press. It's always been thought of it's just needed to protect the lining of the womb. People have forgotten that it's a hormone that's produced and made all over our body, and it's very important for our brains too. It's very calming, it can help with our sleep, it can help with our mood, but it can also be very good for our bone strength, for our heart function, for our muscle function and so forth as well. It really is a forgotten hormone, but we've known for many years, and there were some very instrumental doctors in the past, even as long ago as in the 60s and 70s. There was a doctor called Katerina Dalton who wrote a lot about progesterone, but people didn't want to listen to her. They didn't like the higher doses she was given. She was reported to the GMC. People tried to strip her of her practicing privileges of being a doctor, but she transformed the lives of many women, especially with PMDD and postnatal depression with progesterone. So the natural progesterone can be very beneficial. Now, some people need estradiol too. And when I say estradiol, I really do mean it. Estradiol is the natural form of estrogen that's very anti-inflammatory and very beneficial. We usually give it through the skin as a patch or gel. Now, I've already said the second half of the cycle, there's this drop in estradiol levels. And so sometimes topping up and giving a bit of estradiol can be very beneficial. Again, like the progesterone, we don't have to give it all the way through the cycle. If people are feeling very well at the beginning of the cycle, then we can just give it in the second half. And so sometimes people need some progesterone and some estradiol as well. And sometimes I do levels of estradiol, certainly in the second half of the cycle. And if it's low, then I will often, if people are having symptoms, recommend a trial of estradiol. And then I will often do blood tests going forwards to monitor the absorption of the estradiol as well. Obviously, everyone's different, so I'm just talking very generally. But estradiol is a very low dose. It's very different to the estrogen in contraception. And this is where the confusion so often occurs, because a lot of people with PMDD and PMS are given contraception, and they often either don't feel better or they feel worse. And that's because these are synthetic, chemically altered hormones that won't work the same way in the body. And although they suppress ovulation, so they suppress that spike, that high and low, they don't have the same effects in the body. They don't have the same calming effects on the brain. They don't have the same anti-inflammatory effects either. And so it is very important when you talk about estrogen, or when we talk about estrogen, we're really defining what we mean. And I mean estradiol. So that's the patches or the gel through the skin that some people with PMDD and PMS will improve. Usually with progesterone, I've got some patients who only need the estradiol. They're getting very regular periods. They don't tolerate progesterone, and a tiny bit of estradiol they respond to very well. The doses of estradiol are very low. The equivalent of the synthetic estrogen in contraception is a lot higher, just to reassure you. Also, the estradiol doesn't last very long in the body. So if people use it, it will be out of their body the next day. So it means they can try it for a cycle or two and see if that improves how they are. Any improvement can sometimes take a few months, but even in a few days, some people find that they notice an improvement. So we've got the estradiol through the skin as the patch or gel, the progesterone as an oral capsule, or it can be given as a vaginal or rectal pessary. And then some people I've seen with PMDD and PMS have low testosterone as well. And I've spoken before about testosterone, but testosterone deficiency can lead to symptoms such as low mood, reduced energy, poor concentration, muscle and joint pains, reduced libido, just really reduced pleasure in things as well. And it's always difficult to know whether these symptoms are due to life or whether they're related to a low testosterone. Testosterone levels reduce with age, but some people find that they reduce quicker, especially when people have had their ovaries removed. And so if we are seeing somebody in the clinic, often we will do testosterone levels, and if they are low and the symptoms are persisting despite being on estradiol and progesterone, then I might suggest a trial of testosterone and then repeat levels after 3 months and see how they absorb. It's all very individualised, and these three hormones need to be looked at differently. If someone's still having urinary symptoms, I've already said you can have cystitis or urinary even incontinence, or some urinary tract infections. And if those persist despite having hormones, then often we will give vaginal hormones, either vaginal estrogen or the prasterone, the DHEA, which converts to estrogen and testosterone in the vagina and the surrounding tissues, including the bladder and the urinary tract. So that's an option that we sometimes consider as well. Now, some people are given an injection such as Zoladex, which blocks the hormones working. It's called a GH-RH agonist. And what it does is it just blocks the hormones. And so people very simplistically think if the hormones are blocked, then you won't have PMS or PMDD symptoms. And for some people, it can be a great relief because they're not getting this up and down yo-yo effect, which can trigger the symptoms, as I said at the beginning. Now, the problem is it means that all hormones, as in estrogen, progesterone, testosterone, will then be very low. And these hormone injections will stop those hormones being produced. So a lot of women might feel okay for a month or two, and then they feel dreadful because they've become menopausal literally overnight. But when we give, or when the Zoladex or equivalent injections are given, then it's often worth asking your doctor, what about having some add-back hormones? Because if people have an injection to block their hormones, then what we can do is give the hormones back, but give them at a constant level. So you've got a good amount of estradiol, progesterone, testosterone in the body to stimulate the receptors in the cells to improve your symptoms, but they're given the same amount each day. So then you don't have this fluctuation in ovulation, the fluctuation and then the big decline just before periods. And that can be very good, but Zoladex or the injections on their own can actually ruin people's lives. And I've seen so many women who have been desperate for help. They've had those injections and felt better for, like I say, a month or two, and then they felt absolutely dreadful and been told there's no alternative. Now, the other thing that some people are given is an operation to remove the ovaries, which essentially is as similar to having the injection. People think, and many people still think now, that all the hormones are produced by their ovaries. So if we take out the ovaries, then they won't have any problems with their hormones. Well, as I've said many times before, our hormones are not just produced by our ovaries. Menopause is not just an ovarian problem. It's a brain condition as well. And those hormones are produced in our brain. And the first time I saw somebody who'd had their ovaries removed and told me that she was still getting symptoms throughout her month, and she was still getting this ovulation symptoms in the middle of her cycle, and then this dip before when she would be having her periods, I really was close to not believing her. But I've been always taught in medicine, you have to believe your patients, and any diagnosis is made, or most diagnoses are made, by listening to your patients really, really carefully. And the first lady told me this was actually in her 60s, and she said ever since she'd had her hysterectomy and ovaries removed 20 years before, she got these cyclical symptoms and no one believed her. And I thought, no, I can't be a doctor that doesn't believe her. There must be a reason. And so then I went back to the textbooks, to the papers, to basic physiology, and that's when I first started to read about the role of hormones in our brains. And I thought, gosh, isn't this interesting? So people can still have these cyclical changes in their brain despite having their ovaries removed. So removing the ovaries is not necessarily going to be the best treatment for everybody with PMS and PMDD. Of course, for some women it can help because those levels of hormones will reduce because about half of our hormones are made in our ovaries. But if the ovaries are removed, it's a bit like having the injection. We need to be thinking about, does that person need to have her hormones replaced? And giving the hormones at the same amount, the same dose throughout the month can be really beneficial. For some women, it might just be progesterone they need. They might not need estradiol or testosterone. Some women might need 2 or 3 hormones. But increasingly, we think about giving the progesterone first and then seeing what else is needed and giving the right dose. Some of the treatments are still given off license because of the way that the drugs are licensed, but it doesn't mean it's not safe. There are some studies, there aren't huge studies because, again, the studies haven't been done. But a lack of evidence doesn't mean it's unsafe. All we're doing is giving natural hormones to treat a hormonal problem. But it's not just hormones, of course. We need to be thinking about lifestyle, but we don't really, I don't think, need to be thinking of lifestyle before hormones. Once hormones are replaced, then women often feel a lot better. And that's when we can talk about trying to enable people to live healthier lives. So reducing the amount of processed foods and sugars that they eat can be really good for their mood. Doing regular exercise, looking at the amount of vitamins and minerals that they have, hopefully in their diet, but things like vitamin D can be really important. Iron as well, because iron absorption can be influenced by low estradiol, progesterone and testosterone as well. A lot of people, some of the B-type vitamins can be really important as well. Making sure that people snack regularly as well, because some people get quite a lot of swings with their glucose as well, and that's because our glucose metabolism can be controlled by our hormones as well. So all of this is intertwined. But sorting out hormones first for a hormonal problem makes a lot more sense than just focusing on lifestyle and vitamins or antidepressants as well. Some women are very low in their mood, and some women have clinical depression as well. And for those women, antidepressants or psychiatric medication may of course be of value and really help some women. But we know that antidepressants work better in the presence of estradiol. So that means if a woman is having low hormones, then to give some estradiol to replace the missing hormones means that the antidepressant, especially if it's an SSRI, is going to work more effectively. So they can be given in combination. I used to, years ago, give people antidepressants for 2 out of 4 weeks when they had PMS and PMDD, because that's what I was taught to do. But how ridiculous, because I was giving an antidepressant when the hormone levels were low. So giving those hormone levels back, seeing the response, and then adding an antidepressant for those people who need it, absolutely. But to be thinking about a psychiatric medication on its own without thinking about hormones is not really treating the patient wholly for many cases. So lots to think about there. I hope that's broken it down and made it more simplistic, because it is actually a problem that often can be really easily treated, but the hardest thing is for people to be listened to and understood. In our Newson Health Clinic, we see and speak to a lot of women who are young with PMS and PMDD. I see a lot of women who are in their early 20s who have been diagnosed, or they've diagnosed themselves and they've been given contraception, which has often made their mood worse, made them feel worse, and hasn't been the right treatment. So we have to remember and keep reminding ourselves that contraception is not the same as natural hormones. They are different. Young people can have natural hormones as well if that's what they want, and they should speak to someone who understands the difference. Otherwise, this problem is going to continue. And we also see a lot of women who are perimenopausal who tell us they've had years of experiencing symptoms of PMS, PMDD. Often they've had postnatal depression when they've had babies, and no one has joined the dots, and no one's thought about how important these hormones are in our bodies. And so thinking about how our hormones work, what happens when we don't have them, or what happens when levels of hormones change, makes actually the reasons for replacing with the right dose, the right type of natural hormone to the right woman, a lot easier to understand. So I really hope that's been useful. It's been great for those of you that have joined. Thanks for listening, and thanks for all your questions as well. So I hope you have a great week, and I look forward to seeing you next week and imparting some more of my knowledge and experience with you. So thank you.